All right. I'd like to welcome everyone and thank you very much for attending this virtual forum put on by the American Association for the Surgery of Trauma, or AASD. My name is Thomas Duncan. I'm the Trauma Medical Director at Ventura County Medical Center, and I'm also the chair of the AASD Prevention Committee. Now, the salient topic of how law enforcement and healthcare workers came up during one of our prevention committee meetings, and we realized that it is a hot topic of discussion at many trauma centers. And it has been particularly brought to light by the COVID-19 pandemic. And as such, we felt implored to hold this session. Now, some patients view the emergency department as a safety net or a sanctuary and expect that they're not vulnerable when they come into that situation. But others have thrown that dictum out the window. It is a known fact that healthcare workers take care of patients in the emergency department and often find themselves in a quandary, especially when treating a patient that has life-threatening injuries, but has concerns about certain aspects of their law enforcement interactions. So to address this topic, we have a fantastic lineup of speakers that will begin the discussion of this complex issue and to determine how we can make strides to work together. So I have four speakers. We have Dr. Lia Tatibi, who's going to be speaking about the problem, Dr. Erin Hall, who will be discussing the confusing aspects of hospital guidance, Dr. Andrew Dennis will be talking about the law enforcement perspective, and then Tina Nappi will speak about the potential solution. Now, as a reminder, you can type your questions into the Q&A box, and we will attempt to answer the questions at the end of all presentations. But please direct your questions in a manner of how we can delineate a solution rather than pointing fingers and playing the blame or shame game. So once again, the Q&A section is where you should type in your questions, and the chat is not necessarily where we want those. So without further ado, I will start sharing my screen and we will get on with the program. All right, so once again, we're going to be speaking about the intersection of law enforcement and healthcare, delineating the blurred lines. And once again, I'd like to thank you for joining this session. The first speaker up is Dr. Lia Tatibi. She went to med school at the University of Texas Southwestern, did residency in general surgery at Baylor University and trauma critical care at Northwestern University in Chicago. She recently moved from Cook County Hospital, where she was an assistant professor, to Northwestern University, where she's currently an associate professor of surgery and the associate trauma medical director. And she's the chair of the Chicago Committee on Trauma Advocacy Pillar, as well as the chair of the Women's Surgeons Grants and Fellowships Committee. The special interests include pre-hospital trauma care and injury prevention. So we'll have Dr. Tatebe take it from here.
Thanks so much for joining. I don't have any financial disclosures. Move on. There we go. So we're going to talk a little bit, just starting about how this conversation started up. As Dr. Duncan mentioned, this kind of came up in one of our committee meetings as something that comes up a lot. And if you think about the intersectionality of trauma and who actually shows up for an activation, we of course have our patients, we have the medical team, and the medical team itself can be fairly diverse when it comes to physicians and therapists and nurses and such. But then also we have our pre-hospital providers, and they will include our EMS agencies, our fire department, and then also the law enforcement will usually show up for a lot of our activations, particularly when it comes to victims of violence. And it's important to think of kind of each of us have our own role in protecting that patient, whether it's trying to get them, healed up, saving them from life-threatening injuries, but then also working to help them from an emotional and mental support, and then getting them back out into a safe place for ongoing healing. And so each person involved in that care of that patient has a different priority, but I think we're all sort of there for the same reason. So we want to kind of talk about kind of keeping it really framed in that patient-centered patient-centric way of what roles do we have, how do they overlap, and how can we work together to really provide the best care for our patients? And what does that look like in terms of success? We have a life-saving agency getting back out to the right to full discharge. That's success for us. Our hospital violence intervention providers work on trying to reduce recidivism and get people out and actually in a nicer, healthier environment. That's success. Law enforcement can work on trying to make sure that they solve a situation that's at hand. That's their success. But ultimately, this is all very patient-centric. Can switch on the next slide, please. So I want to pause as well, because this, as it was mentioned, this can be a very heated topic. And we now understand that there have been issues set by both sides and boundaries crossed, but we're really talking about the optimum solution and what we can do to take good care of our patients. And I think it's important as well, just like we do when we talk about implicit biases, of not only for the patients, but also for everybody else. And I think it's important for people on the call to kind of think as well of, what do we think as providers when you see a police officer that shows up with your patient? And do you have a different sense depending on what the situation is? And I would argue we probably shouldn't have a different sense, but everybody was going to have their own bias when you come in. So just sort of pausing and setting that own perspective of where we're starting from, and hopefully we can get a better understanding by the end of this hour as to what we can do to kind of, again, all work towards good care for the patient. All right, next slide, please. And so this is unfortunately the world that we're living in now. This was an actual screenshot from my time at Cook County of a wonderful, beautiful summer day that was, we completely filled up a farm room. And you have a page, you have a list just like this, and you can imagine how many police officers are involved in this, in the situation, right? We've got a bunch of different mechanisms in terms of car wrecks, assaults, stabbings, and a whole bunch of gunshots. And it can be in the patient's best interest to talk to them. Go ahead and move to the next slide. We talk about victims of violence. It actually can be quite helpful to have that early involvement of law enforcement in their care. We want to get the story understanding. We want to be able to try to go out, find out what happened, try to protect if there's any kind of retaliation situation going on, or if there's an active threat against something else. And we don't want to stand in the way of that sort of active investigation, because we want to be advocates for our patients to be able to get the care that they want. Go ahead, next slide. But maybe not this one, right? This is a situation where we don't want law enforcement at bedside. If we're going to be working really hard trying to save a life, that's got to be the priority. And so it's really trying to work to have an understanding of how can we work together collaboratively to make sure we're doing the right thing. Next slide. And going back to our driving factors of what motivates us. So as the medical team, we want to identify and manage life threats, right? So on ATLS, that is where we're going. We want to get an accurate history of what happened, because it matters what we're going to work up, right? If there was a blunt assault along with a penetrating injury, we got to know that. If there were medications on board, illicit drugs on board, that can affect what we do. And so it really does help us to be able to have that trust and rapport, to be able to get a good, accurate history from our patients. And we want to, of course, have a comprehensive workup to avoid any missed injuries, and then work on that safe disposition and counseling towards injury prevention moving forward. The law enforcement have a slightly different take, right? We're working about data gathering for the incident, actually identifying who the victims are, who the offenders are, and uphold the laws and protect the community, and then secure those in custody. And the things that can affect the situation or when those start to maybe overlap a little bit. Next slide. And it's important to know, just was kind of mentioned, that the medical bay or trauma bay should be a sanctuary of sorts, right? We want to be able to get that accurate history. We are not mandatory reporters for a lot of things. We are for some, but not for a lot of things. And we want to have our patients have the trust in us to be able to give an accurate history as to what happened. But that's not always the case, right? We can't just be a complete embassy and say, no, law enforcement cannot come into the situation. If it's a patient in custody, they have to be, right? We have to be able to work together and, again, keep everything very patient-centric. So the next bit of what we're going to talk about is how do we actually come up with an understanding of a conversation on how do we decide who's going to take precedent, what kind of order is it going to be, how do we protect the best interests of the patient and the best interests of the community. Next slide. And we talk a little bit about from our house, right? The law enforcement, they have the laws that they're supposed to uphold, they have their policies and everything else. From the medical side, what do we look at? We have bioethics. That's what drives us. That is our fundamental law of medicine. And that is universal, right? The tricky part about this conversation is local laws and district laws and state laws are going to be are varied. And so we can't give a straightforward fundamental thing where, okay, so Dr. Duncan's out in California. I can't really say that that's going to be the same thing as in DC, as in Illinois. So we can give sort of a basic understanding of what we think should be and the framework to have those conversations. But ultimately, it's going to be up to the local agencies to be able to work together and come across this. So for us, bioethics is fundamental. This is universal across all of medicine. We talk about the 4 general principles. So beneficence above all else, right? Do good. And that can be a situation, like I mentioned, you have a victim of violence who wants to talk to a law enforcement officer to be able to say, this is what happened to me. I want justice. I want to be protected. That we should absolutely advocate for our patients to support that. Secondly, non-maleficence, do no harm. This is going to be another issue when it's like, one of the things that can come up as well in terms of death notification. So say you've got a patient who comes in after a bad car wreck, there was a death in the cabin, the other patient comes in and we're trying to save their life and we're trying to see what life threats there are. Law enforcement wants to let them know about this death on scene or something like that, and there's the control of information. It's probably not the best time to have that information released to that patient because that could cause them psychological harm, which then prevents us from doing our job to be able to take care of them physically. So being able to control that ebb and flow of information is going to be really important by working together with our local agencies. Autonomy comes up a huge part when it comes to this, right? And one thing we're going to talk a little bit about in terms of blood draws and for like legal blood draws for alcohol and driving, right? And again, you got to go back and look at your states and see what the actual laws are. But if you have a patient who's refusing, but then you've got, okay, you've got a court order saying you have to comply with this, and where do those actually cross over, and what do we can do for to advocate for our patients? Same sort of thing with searching belongings. What rights do the patients have to be able to stand up for themselves? And there's a lot of misinformation out there and a lot of lack of understanding and knowledge out there. And so part of it is going to be actually having reliable messengers, credible messengers that have rapport with our patients, with law enforcement, and be able to have those policies to understand how do we work with patient autonomy to maximize that while still upholding the law and collaborating with our law enforcement colleagues. And finally, justice, fair and equitable treatment for our patients, extremely important to us. We want to make sure that not only are we checking our biases for our patients, but also that we're protecting our patients from biases from other people, right? If you have one of our patients come in and she happens to be a sex worker, but she was just raped, she's just as she deserves to have that rape kit just as much as anybody else. And we need to advocate for our patients and understand that they deserve the exact same treatment and check everything else. Next slide. So ultimately, a lot of this is going to come back to communication, as it does in pretty much everything in medicine and in life. And part of it is going to just be really transparent about priorities, keeping it very patient focused, right? I'm just trying to be a patient advocate. We're just trying to make sure I'm not trying to stand in your way, obstruct anything you're trying to do. I just want to make sure the patient's taken care of, keep them in the focus, understand what the priorities are from other sides, and come to a good solution and keep everything de-escalate, try to keep everything calm, keep it on that patient. That can help a lot. Be very respectful and empathetic. Everybody's got a job to do, but we're all here for the same purpose of trying to keep the patient safe and the community safe. And ultimately, a lot of that can be avoided by having clear policies. And so one thing we're going to advocate is taking that time to actually go through and write the policies out, have them looked at from our side and from law enforcement side, and sign off on it. And again, of course, the de-escalation is always a really helpful skill to have. Next slide. All right, so part of this preparedness, again, is to have those policies. So I just put a couple different things that we've come up with on here. There's going to be some more information that our committee is going to be put out. But again, it's a good place to start of very common things, and not everything's going to get sucked into all these nice little bins, but it's a good place to start to open up the communication, open up the conversations within law enforcement, within the hospital, get the higher ups on board from both sides so we can say, hey, look, here's our policy on what it takes to talk to a minor or do our evidence collection or a death notification, deceased viewing. Can you touch the patient? If you have a patient and we're trying to show the mom, that after her son had died, but she can't touch, where are the policies involved? Because we don't want to get in the way of an active investigation as well. And so by going and saying, look, people are not sure what to do, but say, we have a written policy. This has been signed off by risk, by our ethics committee, by the police agencies, and say, here it is. We worked on this together. That can help a lot in de-escalating and avoiding a lot of these situations. And then also providing some local guidance as to how to deal with the situations that are a little bit in between. Next slide. Then of course, you got to have a plan for mediation of what to do at this point. And I think one thing that we're really promoting as well, and Tina's going to talk about this as well, is having the violence intervention people and having the professionals or your social workers, whoever it is, who just sits at the bedside as your patient advocate. Right? They're able to build that rapport. They're not from the medical team. They're not from the legal team. They really are just there to help the patient understand and advocate for their rights and understand what happened. And not only that doesn't help the patient from that side of navigating it, but it also can build a rapport that can help with the process that the HVAPs are trying to do moving forward. So I think that's all I had for starting out. Last slide has feel free again to reach out anytime.
Thank you very much for that, Dr. Tatebe. And now we will move on to Dr. Hall, Dr. Erin Hall. Did her training in medical school at Stanford University and a residency in general surgery at MedStar Georgetown University Hospital, and subsequently went to the Shock Trauma Center for her trauma critical care training. And she has a position as an assistant professor at Georgetown University School of Medicine. And she's also involved in the Department of Surgery and Critical Care at MedStar Washington Hospital Center. And she's the director of the MedStar Washington Hospital Center Community Violence Intervention Center. And her special interests include tracking and understanding the long-term outcomes in trauma care, civil legal needs and survivors of violent injury, and effects of policing in hospitals. And she'll be talking about confusing hospital guidance. And so Dr. Hall, take it away, please.
Great, thank you. I have no financial disclosures. So next slide. I think like most research passions, I came to this work as we do through lived experience. And although I had been aware and frankly, occasionally irritated or disturbed by law enforcement presence in the trauma bay, I never really examined it thoroughly until an interaction between a law enforcement officer and one of my treatment navigators, Gary. So Gary grew up in the tougher neighborhoods of DC. He intermittently ran with the crew, is a survivor of violence, and has been justice involved in the past. As part of our mission at the Violence Intervention Program, we have our treatment navigators respond to all of our high-level trauma activations and be part of the team. This particular day, one of the patrol officers that was accompany all of our victims of violence that come through our bay, for lack of a better word, threw Gary out of the bay. Even though Gary is a professional member of the team doing its job, and despite Gary's explanations, the officer at one point even was holding Gary's ID badge. And what hit me most about this was watching the impact of the patrol officer's demeanor and tone of voice on Gary. The emotional turmoil it created in him. He was just completely and almost instantaneously triggered in almost every way a human being could be. And it was not because he was guilty of something or because he had just gone through a trauma. He was a professional doing his job. But it was really because of his past experiences and his relationships that the impact of this interaction was so profound on him. Next slide. So that experience made me start questioning and examining my assumptions about law enforcement presence in the emergency room and around trauma patients. And when I first started asking, I really started with like, okay, well, what do we know? And it's probably not shocking to any of us that some of our victims of violence may be suspects or perpetrators, but in real fact, we don't know that. What we know is that the patient is a victim of violence and they're here with us because they need our care. Next. Beyond that, I really started thinking, okay, well, what do I think I know? What are my assumptions about this circumstance? And the first assumption I had was that, well, law enforcement, I feel like is common. And I feel like since it's common, it's regulated. That somebody has thought about and examined the risks, the benefits, what should be going on in this situation. I had a feeling that this regulation should probably come from at least the medical perspective of really what our standards and understanding about patient privacy were, and also about the unique medical vulnerability of patients in the trauma bay. And then I thought there had been, or should have been, a careful weighing of the risks and benefits of all of these interactions for all of the stakeholders involved. So that's for the patient, for the staff, for the public. Next slide. And I really, I wouldn't have thought of this at 2 in the morning when I was a little irritated about something happening. But at some point, behind all of my assumptions were that because our enterprise is patient-centered, I thought that when there was conflict, there would be hospital policies that really are there to safeguard patient rights, that comply with policy laws and professional privacy standards, and that are trying to navigate law enforcement interactions in a way that both protects patients and aligns with beneficence, non-maleficence, autonomy, and justice. When I examined and questioned those things kind of one by one, it turns out there's a lot we don't know and that don't exist. And I think because of my training and natural inclination, I really thought like, well, let's dig into the research. What do we know? So next slide. It won't surprise anybody, but just like looking at any exposure, we wanted to say, well, how common is it? We think it's really common. It turns out it is really common. So Eleanor Kaufman just completed a member survey of the AAST, and in it found that 80% observed law enforcement presence at least weekly and 22% daily. And when our group did a month-long observation of our trauma base, we found that law enforcement officers interacted with almost half of our trauma patients. Next slide. And when it comes to benefits, how do we break that down and how do we measure that? Have we measured it? Are there outcomes that we could think about measuring? Certainly, there's the benefit or the attempted benefit at prevention of harm and prevention of additional violence. There's prosecution of criminals. There is research showing that there's increased perception of staff safety, meaning the staff feels safer in certain circumstances. And there's ease of reporting for those that wish to. Next. When we look at the research, looking at the risks of law enforcement interaction with our patients, we see that there can be risks on a number of different levels. One, to the patient-provider relationship. So there can be, and has been reported, perceived prioritization of investigation over treatment, discomfort in sharing accurate information, and implicit or explicit threat of arrest or legal consequences. There's exacerbated bias. Clinicians report less compassionate care towards patients subject to police interest. And all of these things, there's really a disproportionate impact on our patient populations. So young men of color are at highest risk for law enforcement exposure and are also most susceptible to the risks. Next. So in an effort to understand that, to see how does this play out on a national level, are the same things being seen in trauma bays around the country, One of our first steps was to create a national survey of hospital-based violence intervention programs and representatives from each program. And we included interviews and like I said, a survey. The areas of concern were remarkably consistent across programs, and they included questioning without allowing for consent or judgment of capacity, overbroad searches and seizures, privacy concerns with protected health information disclosures, requests for not medically indicated procedures, and controlling disclosures to family. Next. When we asked those same representatives from hospital-based violence intervention programs about their hospital's policies involving law enforcement, we found that most of those policies were found to be inadequate, biased, or unclear. A representative quotation is, "Oh, I think our current policy is really biased. I think it targets individuals and perpetuates systemic racism and forms of injustice." Or one that really rang true for me in my own experience, "I will say there's not clarity about those policies. I think there's, well, this is the way we've always done it." Next. So what is our way forward? One is, as we've said, to try to identify all of the stakeholders and really start with a shared purpose and overlap. That overlap is to protect both patient and public health. The stakeholders include hospital administration, hospital public safety and alternative responses, including BERT teams, providers, and of course, outside law enforcement. Next. I think actually you skipped forward to. So we all want to do the right thing in a complex, high stakes situation. It's sort of custom made for a policy where we all think about it together, where we weigh those risks and benefits, where we encourage mutually agreed upon plans, achievable policies that can reduce harm without impacting public safety mission. And there are some examples of where this has been enacted, and we can look towards treatment of sexual assault victims as a special classification of victim, but one who there have been more thoughtful implementation of policies about. So next. There we have specialized protocols to govern collection of evidence and investigation. There are clearly delineated law enforcement and medical professional roles. There's the guidelines prescribe how victims should be approached. They highlight and make put in the middle a victim's ability to consent and his or her autonomy, including medical vulnerability. And all of that is assessed prior to questioning. Victim retains the autonomy to cooperate as they wish. And there's training and acknowledgement of a role of a victim advocate to help a victim understand what the consequences of his or her decisions are. Now, I think that's all something to work towards and certainly an ideal. But in the meantime, what can we do next? I think it's critical in the meantime to keep open lines of communication, as we said. So understanding the hyper-local mandatory reporting requirements where you practice, and then working with your law enforcement agency to discuss and optimize priorities for reporting that. So we've worked with MPD locally to make a custom designed reporting form that has all of the information that they need most urgently in the way that is most understandable to them. It also highlights which pieces of information are outside those obligations. There are things that we can put into place right now that would help decrease the global harms of the sort of diffuse privacy concerns. And they can include having law enforcement officers check in when they come to the emergency room, and then not being allowed in unauthorized areas or to view patient care activities, particularly of patients that they're not directly involved in. Patients or surrogates should be asked for and give consent, and formal processes are needed to evaluate requests for patient access and information. Next. So ultimately, we are in this together. We all want to improve health But I do think we need to re-examine our assumptions about the way we operate. And I believe it's an opportunity to really reduce harm and improve the efficacy of our violence prevention efforts. And we can think creatively about solution and use all of the tools in our kits to really help this hard problem. Next. I couldn't do any of this work without my violence intervention team. Here are some photos of us, but they've inspired and supported me the whole way.
Thank you very much, Dr. Hall. And we'll move on to Dr. Andrew Dennis. And Dr. Andrew Dennis is a unique individual in the sense that he was an EMT and paramedic prior to going to med school in the Newark, Philadelphia, Kansas City, and Worcester area. And he went to med school at Kansas City College of Osteopathic Medicine and did his residency in Chicago at the Midwestern University College of Osteopathic Medicine affiliated hospitals, and subsequently trained at Cook County Hospital in trauma and critical care. And he's currently the chair of the Division of Pre-Hospital and Resuscitative Traumatology at Cook County Hospital and the associate professor of surgery at Rush University, as well as in the Department of Surgery at Midwestern University. He is in addition a trauma medical director of the Chicago Fire Department and works in patrol. And every once in a while, he may drive around in a patrol car back and forth to work. And he works in the Special Investigations Unit also. One thing special about him is the fact that he's an associate producer and executive medical advisor for NBC's Chicago Med, Fire, and PD. He's got special interest in building relationships with law enforcement and healthcare, as well as quality and wellness. Now, there are only 3 other trauma surgeons and police officers in the United States that, at least that I know of, Dr. Alex Eastman, Dr. Kenji Naba, and Dr. Peter Pappas. So all 4 of them make up a special group. He's going to be talking about law enforcement's perspective. So without further ado, here's Dr. Dennis. And I believe you're muted.
Yes. Thank you. I have no further financial disclosures other than I am the Chief Medical Officer for the Illinois State Police, in addition to being a trauma surgeon at the county. So I've been a full-time sworn police officer for 22 years and a trauma surgeon for 20 years at county. What we want to talk about today, and I think you're going to hear some echoing concepts about the intersections of where law enforcement and public safety, and not really just law enforcement, it's your pre-hospital providers, your paramedics, your EMTs, as well as your police officers, and then federal agents and so on. We do all intersect in the EDs and in the trauma units, and it's not uncommon. In Chicago, there's a law enforcement response with virtually every ambulance call, especially when there's violence associated with it. So as a standard, we typically get 2 paramedics and 2 police officers coming in with every patient at county. So we have 15 resuscitated beds in the trauma unit. And if all 15 beds are full, there's a likelihood that you may have 2 police officers per bed at the same time that the patients are brought in. The objectives I kind of want to talk about are, first of all, we are one team. It's echoed on the back of our shirts at county. Every year we put out 1 or 2 trauma t-shirts that go out to the pre-hospital world. And we always echo the same thing, one team Chicago. Because it really is, it's a partnership, and it's not, our shirts, have the Chicago Police and the Chicago Fire Department, Illinois State Police, but we do interact with all of them on a regular basis. The goal is to work together and not be antagonistic to each other. And the trick is really, how can we help each other? We all have a job to do, and that's the bottom line. So we all went into this for objectives, with the one objective of being of service. I think we have to recognize, and Dr. Tatebe and I have recently published on this in the last year and a half, the overwhelming degree of post-traumatic stress injury that exists in pre-hospital providers, law enforcement, and EMS that goes along with, and the hospital staff simultaneously. So you already have a group of individuals that are intersecting and potentially in a potentially charged environment where unintentional or inherent biases may actually exist and be amplified by post-traumatic stress injury that's simultaneously occurring in all the groups. I think it's paramount that we understand each other's roles, responsibilities, needs, and pressures, because we see what happens on one side of the doors in the EDs and the trauma units, but what we most of us don't see is what happens on the other side of the doors, in the streets, in the homes. What people call homes and what you call a home may be very divergent. So I think that it is really important to truly understand each other and what the stressors are and develop a mutual respect for that. And this is really founded in the ultimate of relationships and communications. Next slide. Unfortunately, most of us get our information from television. So TV is, Law and Order and Chicago Med. I mean, we try to do a good job, but ultimately, remember, these are just carriers for drama. That's it. So we will bastardize, and there may be some truth founded in what we initially say and do and build these shows on, but ultimately they're highly biased. And unfortunately, when we surveyed our audience, and we did this 2 years ago for NBC, 70% of people actually got a tremendous, or admitted to gleaning a tremendous amount of information and thinking it's truth from our procedural television shows. Next. So things I think you really need to understand about law enforcement. Coming from law enforcement historically, law enforcement and EMS and fire agencies, they're paramilitary structures. That is the antithesis of typically what we as physicians exist in. And that means that there's levels of subordinates. There's an ultimate fear in decision-making. So a patrol officer is not going to want to make a decision that's going to usurp or get him in trouble with the detective. There's a fear of punitive judgment or discipline. It's a bureaucratic structure. And ultimately, the bosses are leaned on by pressures from electeds. So you can't just, it's not just what the patrol officer is saying. That patrol officer typically has a mountain of pressure on top of him or her, and fear in making decisions. And this is very clear. We saw this amplified when we were having issues with allowing families to see patients that had passed away and allowing them to see the body. There's a chain of evidence that has to be protected. There's a custody issue of the clothes, of the touching the body, et cetera. And we had a policy and said, yes, you can come see the body, but you can't touch. And most of the time, the patrol officers would stop it and say, no, detectives aren't here yet. You can't come in and see the patient. Well, that we solved this problem by communication with the liaison, to the police department, and we created a joint policy with the Chicago Police Department so that we had a new policy that was understood by the cops, understood by the hospitals, and that was within the general orders of the police department. The other thing that's very important is that circumstances are frequently deeper than they appear. And what I mean by that is that there are unknown stressors that are usually present and not obvious to us. We are focused on one thing, patient care at that point in time, and that's typically what we should be doing. But what if this person you're taking care of just shot and killed a police officer, or shot and killed someone else, or shot and killed a 6-year-old, or whatever? It doesn't matter. There are stressors that may be applying pressure to the pre-hospital providers, that where they just came from a scene and it was a terribly ugly scene, and now they are here. So don't discount that. There's, we have a saying in law enforcement, there are two sides to every story, and the truth is always in the middle. Public safety is a culture. It's a fraternity, a sorority, and it's a family. And it's the post-traumatic stress is significantly under-recognized as a player in it. But keep in mind that, when you see, especially when there's an officer injured, or a cop, or a firefighter or a paramedic that gets injured, there will typically be massive amounts of response in person from that agency, largely because it is important for them to show a moral, to get behind them morally and show a degree of morale. So at the end of the day, we also know that I have salty nurses, I have salty cops, I have salty paramedics. And in Chicago, that's I think that's the default answer, So, but they're also, most of them are highly empathetic as well. So I just want to bring to everyone's attention that our jobs can make us salty individuals. Our jobs can impact us at a deeper degree than others. And I think it's very important that we all give each other just a little bit of latitude when it comes to that. The other thing is cops are typically very ill-equipped to deal with the jobs on the streets. Most of 99% of police officer work is social work. It's social working. It's not violence. It's not getting shot at, unless you're in the 15th, 7th, or 11th district in Chicago, where you go to a gun call every 15 minutes. The rest of policing is, for the most part, how to help society at a social work level. And typically, we have two tools at our disposal. I can take you to jail, meaning I can eliminate your freedom, or I can elicit some other de-escalation solution. But that's it. I have no other tools. We have lack of mental health training. There are just not a lot of other options. So when you call the police, you're calling the police for the purpose of, I have a problem I cannot solve. And if you have a problem you cannot solve, and the only person that responds to that problem is someone that has two options at hand, de-escalate or take away your freedom, none of those are good options. So keep that in mind, because that is what the police officers are facing on the street. And then not to mention you have the lower, 1 to 2% of the time where they're literally facing a life threat on a constant basis. So if you've never been shot at, it's an eye-opening experience. I promise you it is. Next slide. Things to know about us. So what do we know about us? We went into healthcare for reasons of service, same as the police officers did. We prioritize medical issues first, which we should. We protect our patients. We want our hospital and our ER to be a safe space and a place of healing. Many of us, despite good intentions, are unfamiliar with the laws, statutes, and policies. That's key, because it's challenging. Every state is different. Every federal jurisdiction is national, but very rarely are people individually prosecuted under federal statutes. It's local statutes, and they differ dramatically by region and state. And then there are situational pressures on the patients, EMS, law enforcement, and the families. There is often an unintentional bias against law enforcement that can be present, and I spoke to this a few seconds ago. And post-traumatic stress disorder and injury also are rampant and unrecognized. And there's a pressure to perform, to ensure life safety, to improve quality and patient experience, and they're all at play for us. Erin brought up an interesting point about quality in law enforcement, and this is one of my areas of interest, because law enforcement is way behind medicine in quality. We have metrics, but we really don't have national metrics. We don't have national standards to stand by for law enforcement. And that's largely due to the diversity of region. So keep that in mind, because that is something that I think we can strive to work towards, and law enforcement is working towards it. And it's critical that we kind of move towards that a little bit. Next slide. So from a law enforcement perspective, law enforcement is really only the tip of the criminal justice system, right? We're enforcing the laws at the level of the street, but really enforcing laws that are relative to being prosecuted, which is done by the state's attorneys and district attorneys. And then it's the legislatures that make the laws. Statutes and policies differ per state. Medical needs will always trump other needs. Privacy, respect, dignity should always be maintained. And whether, there's a saying also, I grew up in law enforcement, treat everybody like your grandmother or like the president, always have respect for them. But always be prepared to be very defensive if you have to. So it's still paramount. Privacy, respect, and safety are all key. A lot of the discussion that we've had earlier is about private healthcare information. That's important because that is one of the key tenets. We need to protect people, and protecting their private healthcare information is part of it. Some of the things that are common things that do persist across trauma centers are DUI blood draws and consent, minors in the ED. Typically in Illinois, if you want to interview a minor, you have to be a juvenile certified officer to interview the minor. Preservation of evidence, warrants, and court orders. On a more regular basis, we're presented with court orders that historically we never were before, because we know, like in the state police in Illinois, we know that we've often encountered obstructions about patients refusing to submit to a mandatory blood draw for DUI. So if I ask you to do it and the patient says no to consent, you're not going to do it. That was used to be assault. Even though you're protected by statute, it doesn't matter. So now we just go ahead and preemptively get a warrant, and now you have to comply, and you're protected by the court. I think everyone should be familiar with Hipaa exemptions, court orders, warrants, subpoenas, administrative requests, etc. There are a number of law enforcement exemptions that allow you to share private healthcare information with law enforcement and still be compliant with Hipaa. Searches and seizures and clothing and items, again. These depend on where the person is as far as the custody situation goes. And then working within the judicial system to develop guidelines and general orders. Again, you can work together to develop common policies, guidelines. Next slide. Simple definitions I think everybody should have a little bit of understanding is arrest and detain means you are in custody. It doesn't mean you have to read your Miranda rights, by the way. They can be read to you at any given time, but if I place you under arrest, you're in custody. Probable cause means there are enough facts for me to actually search you. Reasonable suspicion means I have reasonable suspicion that a crime has been committed, but I can't search you yet. A court order is a mandated order for you to comply. Same thing with a warrant. Search and seizure is written by the is governed by the Fourth Amendment. Hipaa does have rules and does again have exemptions for law enforcement. There's preservations of evidence that and chain of custody that really have to be addressed and you have to understand them. Juvenile differences differ from state, and then understand what exigent circumstances mean. That it's almost like a carte blanche to get something done. It's like terrorism laws. Next slide. So imagine you have a 44-year-old male comes in as a Cat 1 trauma activation. He's initially evaluated. Life threat is put to the side. Law enforcement follows him in. The police explain to suspect him of DUI that caused injury, and they like a DUI kit drawn. Patient refuses consent. What do you do? Well, in Illinois, this is very common. And we have statute now as of 2015 that was changed to protect the healthcare providers from forcibly drawing someone. What if they refuse? Are you going to hold them down? Some of yours will, some won't. So again, you need to understand what is local to you and what is required in your state and what your hospital policies are. Can you show the officer the blood alcohol? Can you print out your medical record for the blood alcohol for the record that you drew? At our hospital, we can show them the number on the screen, but we can't print out the record for them. If they want that, they have to subpoena it. Next slide. And then, we talked about this. What happens when a cop gets hurt or a fireman gets hurt and you have hundreds of people showing up in the ED, clogging up what you're trying to do and actually impeding progress of patient care? This is where you have to have liaisons. You have to assign people. Because this is highly emotional, highly charged. And God forbid you have the offender and the officer in the trauma unit at the same time, you're really you will be in a true crisis. So again, these are things you should be prepared for. You should understand that you should have a liaison, but be careful because you'll have a lot of cops close to the officer, and it's very easy to share information they may not want shared because the officer, in this case, may be a patient as well. So again, certain things come up, and they in our world they come up very frequently at county. Next slide. Simple solutions. I'm going to end with this, and I'm a big fan of solutions, and I know I haven't given everybody a blanket solution for everything because it's impossible. But I think it's really important to learn more about each other's jobs. You have to build relationships. The world runs on relationships. Our cops come to us to get training. We work on tourniquet training. We teach them Israeli bandages, whatever. It doesn't matter. We want to be a resource for our police officers and our paramedics. We provide outreach. We want our nurses always have a carte blanche to ride with the cops and with the paramedics. You got to see what the other person does, just like the cops need to see and understand what you do. So as long as you're a resource and you open those doors, you build relationships. And then it's not just, oh, Doc Dennis, he's out to beef me. It's Doc Dennis. Oh, I'm cool. How can I help you? How can we help each other? So designate liaisons. That goes a long way. And someone that's on call 24/7 that can be the liaison, because these things always happen at 0 dark 100, right? And now you have no resources at hand, and you're in the middle of a fight, and you're trying not to get someone arrested for pissing off somebody else. Mutual awareness, level of training. Understand that a patrol officer is a patrol officer, a white shirt's a white shirt, and if you don't get what you need from the patrol officer, then they have levels of supervisor. Again, it's militaristic, paramilitaristic. Then I implore you just to kind of recognize that there is a undiagnosed degree of post-traumatic stress injury that is simultaneously occurring in everybody. So as long as we appreciate that and accept that, we can de-escalate each other, and typically we can get along. And that's really, again, it goes back to one team. I think that's my last slide. Thank you.
All right, thank you very much, Dr. Dennis. By the way, as far as questions and answers, like I mentioned, we'll get to them at the end of all the presentations. And in the event that we can't answer your question, you can always connect with any one of our presenters today. So the closer will be Tina Nappi. Tina graduated from Boston University with a bachelor's in journalism and got her master's in social work at Boston University also. She managed the Office for Victims of Crime at the Brigham and Women's Hospital and is an advocate, program director, and consultant, and advanced equity and trauma-informed and healing center practices. And she's done a lot of public health response to violence in the Boston area hospitals in the past. And she's currently the director of organizational growth as well as equity at the Hospital Alliance for Violence Intervention, also known as the Hobby. And she's designed and implemented and led, as well as evaluated multiple healthcare-based violence intervention programs. She's going to talk about potential solutions. So Tina, here you go.
Thank you so much, Dr. Duncan, and I don't have any financial disclosures. Okay, so thank you again for inviting me to speak on this panel. I want to start by telling you a little bit about the work at the Health Alliance for Violence Intervention, the HAVI. We are a national network that works to heal violence, and we do that by fostering hospital and community collaborations, really to advance equitable trauma-informed care and violence intervention and prevention programs. Next slide, please. And at the HAVI, we view community violence through a public health lens, and we really work to promote and support hospital-based violence intervention programs, which is an evidence-based model shown to reduce the risk of retaliation and re-injury. And HVIPs, as we call them, are multidisciplinary programs that combine the efforts of the medical staff with trusted community-based partners to really provide safety planning, wraparound supports, comprehensive case management to violently injured people, many of whom are boys and men of color. And HVIPs do this, as Dr. Tatebe said, by employing sort of violence prevention professionals. These are credible messengers, sometimes also called violence intervention specialists or navigators, who really have their own lived experiences of community violence and really reflect the identities of the people that they are supporting. And I think this is really important because at the core of this HVIP model is a bedside response at the time or very close to the time of the injury, which really presents this moment that we call sort of a golden window of opportunity to interrupt the cycle of violence. And we do that by building trust and really advocating for that person in that moment with a lot of empathy and care. And that HVIP support continues after patients are released from the hospital and will follow people long-term. I think this is really important because HVIPs support people who have obviously a lot of contact with law enforcement or justice involved, and they really can help sort of the patients understand their rights. And while they're focusing on the individual safety, they're also looking at the broader sort of community safety. So this concept of we are part of like one team is really important. So HVIPs interact with law enforcement regularly. They're trying to understand the status of the investigation if there's one ongoing, but they're also trying to advocate for patients so that they know what their rights are. And many of our HVIPs have developed really effective collaborations with law enforcement. Next slide, please. And so the HAVI is a growing network. We have currently 50 member programs across the United States, and in the UK and Central America. We also have about 35 emerging programs. And we accomplish our mission through a number of different strategies. And I just want to give you this context because it's important for how we're thinking about this issue. So we're starting with sort of looking at systems and narrative change. Our work really begins with this deep recognition that victims and survivors of community violence and people of color in particular are worthy of care and support in the wake of their pain. And we really believe that it's essential to kind of address structural racism and lift up opportunities for community transformation and making sure that we're amplifying the work of those folks kind of on the front lines. Through our policy work, the HAVI is advocating to resource the work of HVIPs. And really, we've spent a lot of time developing sustainable funding paths through federal and state policy work. We provide technical assistance to build capacity for the HVIP model, but we also do that by helping develop partnerships put up among hospital, city, county, and community leaders, and again, including law enforcement. And the piece that I want to emphasize in terms of our work in this area that we're talking about today is that we have this sort of philosophy and approach of peer learning, really bringing together kind of communities of practice of folks who are really grounded in the values of equity, community, trauma-informed leadership. And we host a number of forums every month called sort of working groups. And there's one very specifically that we've lifted up called Reimagining the Public Safety, where we're bringing together member programs, HVIPs across the country to really look at this issue of interaction with law enforcement and how can we work together, because we believe that the solutions really come from those who are closest to the problem. And this one sort of working group called Reimagining the Public Safety, I just want to acknowledge, is co-chaired by two leaders of our member programs, Dr. Erin Hall, who's with us today, and Mr. Johnny Williams, who's the executive director at GRASP, which is a program in Denver that works in the Denver hospitals. And these, we're so fortunate to have these incredible experts who've been facilitating discussions with about 15 hospitals across the country, where we've heard a lot of the same themes that have been talked about today from violence prevention professionals who are really sharing some of the challenges and the opportunities to collaborate. And next slide, please. And so what I was asked to do is to kind of summarize some possible solutions and to address kind of these blurry lines. And I just want to lift up these three areas and touch upon them briefly. The first is really that it can really help us to frame the issue of community violence through the lens of trauma-informed care and racial equity. Just thinking about exposure to trauma for everyone involved, certainly the victim of violence, but also the healthcare providers and law enforcement. Second, to really work on developing policies, and I'll tell you a little bit more about what we're doing at the HAVI. And then the third is to kind of explore pathways for effective collaboration. And I'll tell you a little bit more about those in brief. Next slide, please. So you may all know this framework well, but I just want to sort of lift it up because I think it is incredibly important and valuable to us as we work through this issue to really respond to people after a violent injury, to see their humanity and to provide the highest quality and the most compassionate care. And so essentially walking through these 6 guiding principles of trauma-informed care is really how HVIPs or in violence prevention professionals kind of approach their work. This is a system of care that guides kind of a healing-centered approach and an equity approach that sees a person even at their most vulnerable time as somebody who's got strengths and opportunities for resilience. And I think this approach really helps us to kind of create trust and mutuality and respect for self-determination and autonomy. And I think that especially in working with law enforcement, I do want to emphasize kind of sort of number 6 in terms of cultural, historical, and gender issues. And just to elaborate that I think that this is a really important frame around racial equity and understanding the lived experiences of people who are violently injured, the intersection of race, historical, and generational trauma. This is essential. And as Dr. Hall talked about, not just for violently injured patients, but also our workforce, interventionists, and as well as Dr. Dennis said, law enforcement. So I think this is a really important framework because it helps us to think about the sort of collective trauma, sort of the history of policing in communities of color, and just acknowledging that framework, understanding and factoring that into how we approach the care. And I think that that can really help us kind of, again, come together kind of with this framework. Next slide, please. And so I think one of the pieces of work that I wanted to share with you all is that we are looking at kind of best practices in hospital policies as a strategy to really look at systems change, really kind of ways that we can respond. And again, just appreciating Dr. Hall and Mr. Williams in Denver, who've been leading a group, really talking and looking at kind of what some of the policies are already in effect in our respective institutions, really doing an analysis kind of with our member programs to really understand kind of the areas that we might be able to already have sort of some policies that are useful to us, like some of the visitor policies, some of the sort of points of access, but then where are the places where we need to strengthen? Because we know that understanding roles is an essential sort of piece of this. We also sort of want to make sure that our violence prevention professionals have access to someone at the bedside to like capitalize on that opportunity for change to kind of interrupt the cycle of violence. But also having a clear policy helps us to address the implicit bias. And I think this is part of the narrative change work that I mentioned earlier, we really want to make sure that we're viewing the person who is the victim of violence as somebody who is experiencing a trauma and a patient who is kind of worthy of care, and make sure that they are not there's not interference in that access for them. And I think also just it's important to kind of unpack some of the nuances and complexities that we've all talked about on this panel today, is understanding that sometimes a person may not be sort of accessible to law enforcement in that trauma bay, obviously because they may not be clinically or medically stable, but also because of the psychological trauma of the situation, that they may not be at a place where they can talk about what they experienced. And so again, this gets back to really creating an opportunity and a tool so that we can understand kind of our role from the healthcare perspective, and then also be able to share that with law enforcement. Next slide, please. And so I'm just going to wrap up and not spend so much time looking at that. It's about the top of the hour here, but I do think that Dr. Dennis talked about this as well as Dr. Hall and Dr. Tatebe, is I think that having a clear sort of opportunity for collaboration, lines of communication being open between our systems. But I also want to just acknowledge the points of tension. I think that that's a way forward for us as a field and as a community, sort of like understanding kind of how we come into the space and kind of how our systems each operate. And I think there's a tremendous opportunity for mutual learning and cross-training and sort of building a system together. And so my last slide, we can advance that, just is as a way of summary, is I just want to say that sort of I think centering racial equity and trauma-informed care are some of the pathways forward to that sort of place of mutual accountability, respect, and compassion. And I'm looking forward to continuing this dialogue with all of you. Thank you.
Thank you very much, Tina, for that great presentation. Now we'll go into the Q&A section. Although prior to doing that, I want to remind people to turn in their sign-in sheets by this Friday, the 25th. There will be CME offered later on, and that's going to be collaborated by the organization of the WASD. And the next grand rounds will be happening on April 20th, next month. The speakers are Dr. Dumas, Dillon, and Coleman, and the moderator will be Lisa Knowlton. So let's go. I'm going to stop sharing my screen and we'll go to the Q&A for the question that we have. There's a question from Julie Cruz. She wants to know how the situation with Gary was handled. And this question is for Dr. Hall.
Yeah, we had a multi-pronged approach. Our first response was to try to help and support Gary and what he was going through. And actually he accessed our employment assistant program. So all the doctors, I'm sure, are familiar with EAPs, but he took advantage of that. And then we had a series of meetings with MPD and the particular patrol folks involved. A lot about explaining the role of hospital-based violence intervention and opening up that conversation about, again, understanding each other's roles, but also respecting what each had to offer the other.
Okay, great. Now, there's a question from Eleanor Kaufman, and she wants to thank all of us for the topic. And she agrees that the key standards should be patient-centered care. And she's wondering what evidence there is that early law enforcement involvement benefits our patients. And also what evidence is there that early law enforcement involvement benefits the public outside of the rare, true, active danger scenarios. So I'll let Dr. Dennis take that.
I don't know that there's evidence. I really, every individual has a different circumstance, and why the police are there is usually different for most people. I think you have to appreciate that the police are running from call to call. If you took our state troopers, for example, they literally go from crash to crash to crash, or stop to stop. And when they accompany the patient in, they have a job to do. They've got to get the DUI paperwork done. They have to apply for charges. If that's the case, the direction they're going to go, they have to investigate, do all the paperwork for the accident or crash investigation. So there's a lot of pressure on them, and they have to do it within a short period of time, because Typically, though, that takes the officer off the street for DUI, takes them off the street for 2 to 3 hours in order to do all that necessary paperwork. So they have pressures from their superiors in order to clear the cases and get things done and get things moving. The public puts pressure on the law enforcement and the state's attorneys and the legislature to solve crimes and to prevent crimes, obviously, but to solve crimes. So the question is, is there data to support direct involvement? I guess it's kind of an open-ended question. We know that there are pressures on the cops to get their job done, as we have pressures on us to get our job done. And paperwork is the bane of everyone's existence, including us.
I did mention this to Dr. Kaufman as well, but when I've been looking for the background for the paper that's going to be associated with this, I was able to find data to suggest that for homicides direct, like the faster you can get through and get information, that yes, the closure rates are higher. But I have not been able to find evidence to other than homicides, does actually having the officer at bedside in that moment versus 3 hours later when it is better. I'm not sure that data exists right now, but I would defer to Dr. Dennis and the other officers.
It's very hard data to get because every circumstance is a little different. If the officers are at the bedside because they're looking for an offender that just shot up a bank and killed 5 people, and the person at bed may have an answer, well, then that has pressing exigent circumstance. If it's a drive-by shooting that no one's going to talk to the cops and no one has any witnesses, and it's unlikely to ever be solved, then no, we probably won't have much impact on the world. So again, it's very unique to the circumstance.
Well, there's another question from an anonymous attendee. How can we streamline this process when we live in an area with several law enforcement agencies?
I can answer that. That's actually not a hard question. So in the suburbs, typically, especially when you get out of one city where you have one jurisdiction, you do deal with multiple agencies. So in Cook County, there are 53 law enforcement agencies, and it's outside of Chicago. If you're at Lutheran Hospital, for example, you'll deal with 20 of those different agencies. There's the Illinois Chiefs Association. There is the International Association of Chiefs of Police. There's the Illinois Sheriff's Association. There's all these groups that bring these groups together. In Northern Illinois, there's Northern Illinois Police Alarm System. And so there are groups that bring everyone together that you can affect policy and change through and mutually. You just have to ask.
Now, is there a conference that happens on a yearly basis where law enforcement gets together and sometimes healthcare professionals can be in attendance?
So International Association of Chiefs of Police, both Dr. Eastman and I have sat on that board, has a physician section. It's a national meeting. There's 30,000 people that attend, and there's bosses from all over the country, all over the world that attend that meeting. It floats around the United States and North America and South America. So that's a great meeting to kind of get involved in. We've presented a couple times recently at the physician section from all kinds of topics related from enforcement to occupational or whatever. And then there's the local meetings. I mean, just like medicine, there's state and local meetings on a regular basis. Every state has a state police agency. That state police agency is typically looked to as the leader in law enforcement, and most local agencies will follow what the state agencies do. And then in Illinois, for example, we have the Illinois Law Enforcement Training Standards Board that governs policy and how we train our cops and what they can and cannot do as far as training goes, at least. So if we want, for example, when we wanted to roll out critical incident training and dealing with emotionally disturbed people, that got rolled out through the Illinois Training and Standards Board. And every state has a board like that. California, it's called POST. Arizona, it's called something else, etc.
Well, Tina, I know you're working on a document, and the policy document, a foundational document. When can people expect it to come out, and when will it be rolled out? I mean, that's the big question on everyone's mind.
Yes. Sure. I mean, we do have kind of a short kind of summary of considerations that I'm happy to send out to anyone interested now. But in terms of kind of what that template document, we're really moving forward with a subcommittee and hoping to get something out kind of later this spring. We do have a law student who's just signed on to work with us, so we're excited about that. I think that's going to expedite it. So stay tuned, but hopefully sooner than later.
All right, excellent. I know we're 10 minutes over, so we'll probably end this in about a minute or so. Dr. Tatebe, since you are in Chicago and you see, unfortunately, a high degree of penetrating trauma, do patients actually not want to come to the hospital because they feel distrustful of the system, then want to stay either at home or wherever they got injured? Will they rather stay out than come to the hospital because they're going to be confronted by law enforcement officers?
Well, I mean, there's a selection bias. I don't know how many people don't show up, which is something, of course, that Dr. Hake has been looking at a whole bunch too of what happens with the non-fatal firearm injuries. I'm sure there are. We definitely get people who come in and refuse to give their name. We certainly had one time a patient came in and tried to give a different name and actually ended up, the officer who showed up was able to find their ID, ran it and found out he had an active warrant and of an unrelated charge, and actually was arrested because of that. So there is for sure conflicting interests and a lot of concern about that.
A lot of our patients run to Indiana to go to the hospital, but then Indiana doesn't really have a robust trauma system, so they transfer to the trauma centers in Illinois and Chicago, and their encounters are back where they started.
So it's like a boomerang effect.
Yeah.
All right, well, the last question I have is for Dr. Hall. Have there been cases in which healthcare workers have suffered legal ramifications from refusing to abide by law enforcement in terms of their request for patient-sensitive information?
Well, I think the most famous case is probably the nurse in Salt Lake City who was arrested for refusing to draw blood. Although she was arrested, she got a settlement for millions of dollars from Salt Lake City. So I think in all of this, it's really interesting the differences between what laws allow you to do as a physician versus what laws compel you to do or make you do. And that it really is important for all of us to understand that difference and to just have a clear knowledge of what the policies are and what the implications are.
All righty. I think there's one more question, then we'll end it from Steph Preston. Are police policies for conduct within hospitals generally publicly accessible, or something you have to obtain from someone inside the police department?
Policies are usually, I mean, they're public agencies, you can FOIA them, and you should be able to get any policy via a FOIA request. So if, you know, the government agencies, everything is subject to FOIA when it comes to policy, because they're accessible. But the question is, do those policies actually exist? I doubt it. There are probably no policies with regard to that. It's the hospital policies that actually govern it. But if the hospital policy is in conflict with statutory requirements that the officers have to abide by or need to do, then the statute supersedes. And that's where the conflict occurs. So the goal is really to have those guidelines and policies ironed out, and the places that you know are of low-hanging fruit of conflict that we commonly occur or encounter.
I mean, I think that's absolutely right. When we've talked to different police departments, and our own DC police department doesn't have a specific hospital policy. But I think it makes me optimistic that we actually have power to shape that through hospital policies and through this this process of working together, because it allows us to honor the patient, to put forward our own sort of concerns about that specific medical vulnerability, as well as our professional and ethical standards around privacy. And so there's actually quite a bit of leeway if the organizations are speaking to each other.
And then just so someone asked this earlier, but you know, county, we do have a sign-in requirement for the officers. They approach the front desk, they sign in, and they put the RD number or the case number that they're working on assigned to that patient in the book. So we have a linear way to track the law enforcement tracking system in conjunction with the medical record number and the patient name. So if there is conflict or if there is an issue, we're able to actually backtrack through it.
All right, well, thank you very much. Once again, Tina, Andrew, Leah, and Erin, thank you for being a part of this great conversation. I'd like to remind people to turn in their sign-in sheets by Friday, March 25th, and then look out for next month's grand rounds on April 20th. So have a great evening, and we shall regroup again. Bye-bye.